and welcome to yet another episode of Guest Room. Today we have with us Shula Ramon Professor from Anglia Ruskin University of Cambridge, and she is specialized in mental health recovery and social inclusion. Welcome, Professor. Welcome to our show.
Thank you.
Can you please tell us something about yourself?
Hello, it's very nice of you to invite me. My name is Shula Ramon. I'm working at Anglia Ruskin University in Cambridge. I am a research professor specializing in mental health. I'm both a social worker and a clinical psychologist by my training, and I've been a research professor for quite some time. This means that I do research, I manage research, I lead it. I have many PhD students. I teach very little compared to other people. It's not always easy to do it, especially because I am very keen to do what is called participatory action research. In participatory action research, you try and involve other people as co-researchers. And also you are interested in what they want to get from the research. And so the aim of the research is partly to enable people to participate, to be involved, but also to follow what they would like to change. The aim of this type of research is to change something. In my case, in the practice of mental health services. I've done a lot of international work.
Okay.
At present, I'm involved in a project in Italy. And also our master's online on mental health recovery and social inclusion is a co-production of people from the University of Hertfordshire, the Institute of Neurology and Psychiatry in Warsaw in Poland, the Department of Psychiatry in the University of New Lisbon in Portugal, and the Department of Psychology in the University of Turin. So this is just to give you some examples.
Well, Professor, recovery seems to be an important new area in mental health. Could you please tell us more about it?
Yes, it's not that recovery is a new area, but there's a new meaning given to the word recovery. The new meaning means that we are not aiming to cure people or to get rid of all of the symptoms they may have, but we are trying to find ways in which they can live better with the illness and to live beyond the illness, with many activities that are part of everyday life. So it's a new way of thinking about how to support people who have serious mental ill health. Yeah.
Could you please tell us the challenges that you face while teaching, social workers?
Quite a lot of social work students, I think, are afraid of mental ill health and afraid of working with people with this problem, because the social stigma about it means that they are supposed to be, totally mad, crazy, they don't understand anything, they hallucinate, things like that. There is a small minority that always was curious about mental ill health, who is very keen. So one of the challenges is how to enable those who are afraid of mental ill health to recognize that there's a very wide range of people and conditions within mental health, and that on the whole mental ill people don't attack other people. They are more likely to harm themselves when they are very unhappy.
Oh, that's unfortunate.
Yeah, but they usually are too peaceful and too passive. Yeah.
Okay, there are two kinds.
Yes, there are two kinds, but the majority is not going to harm other people.
But themselves.
But if at all, then they would harm themselves. Because this illness means that people they lack in self-confidence. They don't believe that they are any good. You see it especially in depression. But even when people have what we call bipolar, mania and depression, in a manic state, they're just over the moon, and it's very difficult to stop them, and they have no boundary. But usually they fall then into very deep depression, in which again the difficulties are that they think they do not deserve to live, they do not deserve anything. Yeah. The other major psychotic illness, the serious illness, is called schizophrenia. And schizophrenia is more about people seeing things that do not exist, hearing voices sometimes that tell them to do bad things, especially to themselves. And so they are not in full control over their reality. But quite often they too are depressed. It's very common to have depression and schizophrenia. So people normally do not know it. So we have to teach our students about the range and about why we think people become mentally ill. Medics usually think that this has to do with biological reasons, with brain dysfunction. But when you come from social work, you usually think that it has to do with personal factors or life events, traumatic life events, as well as maybe vulnerability to this particular illness. So we also have to show them how social factors come into play. People who have serious mental illness on the whole are very poor, partly because they can't work a long time. So when you are poor, there are a lot of things you can't do because you cannot afford them. And also the social view about you is that you are a failure. So this adds to the difficulties. A lot of people with mental illness, when they feel a bit better, would like to work. But it doesn't mean that it's easy for them to get a job. Because again, the stigma is very active and employers are not very keen. But we have some very good examples of success in employment of people with serious mental illness. The best example that I can give is an innovation in England, which came to us from the United States, where we are training people who have serious mental illness to work alongside people with mental illness. So they are not working in the service in which they are patients, but they are working in the nearby service. And they work part-time. And they are very good at it. They're very natural in befriending people with mental ill health. And I've been also teaching them a little bit on their training. It's a joy to teach them. And then it's such a pleasure to see how they work, how they intuitively know which angle to go from, and the way they approach people. And this is a good example of what recovery can do.
Yes.
Yeah, they haven't stopped being patients. They may or may not be on medication, but this doesn't stop them from being able to do other things.
Could you please tell us more about your research?
Thank you. I can start with my current research because I have also a lot of research that is part of the past. The latest project, which I just finished in July, was trying to put in place an innovation in the way mental health services work. This was about putting in place a process of shared decision making between a clinician and a patient around medication. Usually it's the doctor who decides, and the assumption is that the doctor knows a lot about medication. What we are arguing is because the patient takes the medication, they know a lot about it too, but from a different perspective.
Right.
They know more about it experientially, from their experiential knowledge, whereas the psychiatrist knows from their scientific knowledge. And therefore, a good decision is one that takes both perspectives together. We are not giving advice to anybody on medication in that project, but we are showing them how to put in place a process that each of them contributes to the decision. To do that, we applied for research funding from the National Institute of Health Research in the UK. And when I say we, it was a very mixed group. It was some psychiatrists, some psychologists, some nurses, and some service users, people who are patients as well, and people like myself who are both clinical psychologists, social worker, but have experience of doing research. And when we got the funding, what we asked the funding for was to put in place a training program, parallel training programs, one for the people who use mental health services, one for psychiatrists, and the third for people we call care coordinators. Care coordinators are a mixture. They could be nurses, they could be psychologists, could be social workers, they could be occupational therapists. They are responsible to coordinate a case, a person, the work with a person. The reason why we thought we can't put them all together is because they are not used to being together. And we were, as a group, and we were afraid that if we will make them be together, they will not feel safe to say what they really want to say. And it was important that the group atmosphere will be free and informal. We chose groups because groups are very good in enabling people to share things in solidarity, also in creating an atmosphere that people can give and take to each other. And it's basically also more economical. It takes less time working in a group than working with each of those people individually. But to get even to the training, we had done an international literature review, and we did 7 consultation groups where we asked people from the different groups what they think about the idea of shared decision making. And what they told us, all of them, it's a very good idea, but. And then there was a long list of what they consider to be barriers, and a very small list of what they consider facilitators of this change. So we learned from the consultation, we learned from the literature, the international literature, in terms of knowing where there are similar programs. There aren't many, and this was the first ever in the UK. So on the basis of that, we created a training. The training is similar for the 3 groups up to a point. It is about the process of shared decision making, how to listen to each other, how to prepare, especially the patients, for the meeting with the psychiatrist in advance, what type of questions they want to ask, what they are not sure about, what they are very unhappy about, all of those type of things. And we shared with all of the groups our knowledge about the international project in this area, what they show, and also the tools of evaluation. It was very important to evaluate if this works. So we had a pre-program evaluation, an immediate post-program, and a year later to see if the change that has taken place will survive the time and all of the problems, yeah. And perhaps it will be interesting to people who will watch this video. The primary outcome that we wanted to achieve was a reduction in conflictual decision making, where there is disagreement between the 2 partners. And we took a tool that is used very widely in cancer counseling, when people have to make decisions which are irreversible, whether to continue treatment, to stop treatment, all of that. And I have to say, we are very pleased that actually our project did lead to reduction, statistically significant reduction in that conflict.
Oh, that's nice.
We then did the training, and in each group we had 2 co-leaders of the training. One was a psychiatrist and one was a service user trainer. We have people who are patient, but also learned how to train groups.
Okay.
And because we wanted to show that this is a shared process, it was very important that the leadership too will demonstrate that it's possible to do it like that. And in fact, it was a very positive experience, because we asked, separately afterwards, the leaders as well, what was it like for them. We didn't have much time with the psychiatrists because they are actually very busy people.
True.
in our mental health system, each of them has 500 people on their books that they have to see about every 6 months. So to take their time for training was something special. We had a little bit more time with the care coordinators, and we had a lot more time with the people who use services. With the people who use services, we also focused on how to become positively assertive, how to learn to say what you want in a way that people will listen. There's a title of an article from another relevant study that says how to speak to your psychiatrist. There are ways, if you just tell people about your frustrations and you're angry, they're less likely to listen to you than if you tell them the same things, exactly the same things, but in a nice way. So we actually were teaching the service users how to frame the question, to think in advance what it is I want to ask, what really bothers me about medication.
Okay.
What I'm not ready to continue. But then to say it in a way that the other side can hear it. So that it will be effective, you're doing. Yeah. It's effective communication. Yeah. And this was not always easy because these people that we worked with had on average 15 years as mental health patient. And they were on 5 medication each. And were lacking in self-confidence. But I think what helped was that they were working in a group where they could share with each other. They did exercises, role plays, things like that. They also saw videos where we showed them how people can ask questions, things like that. And also that one of the core leaders was a service user.
Okay.
So there was a live example of someone who has done it. Yeah.
Who's experienced it for themselves.
Yeah. We developed 3 forms as well, so that people can use it to write briefly, not a lot, and to communicate in that way. And we use professional actors to create 4 conflictual situations around shared decision making and psychiatric medication. To show that there is a range of situations and also patients behave in different ways, psychiatrists behave in different ways. We also had family doctors in the situation and nurses. And we had, in one case, we had the husband of the wife who is coming with a problem. And there's a little bit of sense of humor in those scenarios too. So that's what we did, and then we did the evaluation a year later.
And could you
the results, yes, the main findings are that it was successful with the people who use services in reducing the level of conflict around the decision.
Okay.
That they felt that their psychiatrists were listening to them better, and that they were very happy with the groups. They really appreciated it. So much so that when we finished the groups, they asked for more groups. So what we did is we didn't do exactly the same, but we had once every 2nd month a support meeting for them in the different places where we had the groups. The professionals were very pleased with the opportunity to talk about this topic because they said that usually it's not talked about. People assume all sort of assumptions, but they don't freely talk about it. So through the interaction in the groups that we had for the professionals, this became possible for them. Also, they really valued having a ring-fenced time. Because they're so busy, they wanted time out of work to do that. But not all of them came back for the evaluation a year later. And we think this is because there were a lot of changes in the structure of the mental health unit that we were working in. What happened now, after we finished the project, the chief executive of the unit and the medical director of the unit were very impressed with our project. I forgot to say also, we did a cost-effectiveness analysis, which does show that for a large number of people in the group, this way of working reduces cost and improves the results. So the people at the top wanted to continue, and they decided that this will become policy not only for the pathway in which we worked, which was rehab and rehabilitation, but for all of the trusts, all of the units. And now we are working with every team on introducing them to this idea and how to work around shared decision making. We are working with all of the service users. There are a lot of issues about how you can give information to people who are not scientists, and also to enable them to decide which information is good information. Today on the internet, it's very easy to find a lot of information. Doesn't mean it's the right information. So it's tricky.
It is.
Also, because those people have been patients for such a long time, many of them are not used to computers. So there is an issue. How do you give this information to people who are not able to use computers? Anyone who wanted to learn, our research assistant were ready to teach them. And we actually have some people who learned for the first time to use computer because of our project. And in our website, we have a big website, they can get directly to three websites, three very good websites on medication. We also invited a pharmacist to talk to them about medication, and also to tell them that they can go to the pharmacist for advice. They loved those sessions. They really loved it. And I was very surprised that they never have been to the pharmacist before. I'm talking about 50 people, and none of them have been to the pharmacist. So this is what we are doing right now. We also started to train the peer support workers on shared decision making. And next year in the university, we will have a special master's level course on shared decision making for psychiatrists, pharmacists, and we also have nurses with special training in giving medication. We call them non-medical prescribers. So this is what we are going to do as well.
Well, that's
This
nice,
is just
yes.
one project.
This is
I
just
do
one
have
project.
others, but I think it's enough to illustrate what I'm trying to do.
So, ma'am, do you have any message for our viewers?
I think my message is, I hope that the viewers would be able to look at people who have mental ill health as people first, and to remember that they may have problems at the psychological level, they may have an emotional crisis, but they have many other qualities which we can all benefit from if they would be allowed to develop their strengths. So really my plea is not to focus on the stigma, which has no justification in reality, but to treat those people as human beings and to see the good things about them, which I think our study demonstrated, that they are capable intellectually and emotionally to learn new things, to contribute to the work that they do with psychiatrists and to many other things.
Thank you, Professor, for being with us today. We indeed had a pleasurable time with you.
Thank you.
Until we meet for the next time, this is Chitira signing off.